Hello everyone, welcome back. Today I'll be covering multiple hereditary exostosis MHEs, a part 1 video. Started off with an introduction, formation of exostosis, malignant transformation, and clinical manifestation. As an introduction, hereditary multiple exostosis HMEs syndrome, also known as multiple osteochondromas, hereditary deforming chondrodysplasia, multiple cartilaginous exostosis, or diffuse ecclesis. HMEs develop in early childhood as benign multiple cartilage capped bone tumors or osteochondromas, mainly involve a long bone metaphysis and diaphysis, including ribs, but rarely the scapula, vertebrae, pelvis, and sporadically the calvarial base. This is by Sinha et al. 2017. Consequently, affected individuals may present as a reduction of skeletal growth, short stature, bone deformities, scoliosis, premature osteoarthrosis, or compression of the peripheral nerve by Woods et al. 1993. Most severe complication of MHE is sporadic malignant transformation into chondrosarcoma, which risk depends on age, sex, genotype, and anatomical distribution of exostosis. By Stable and Dormans 2005, Zetska and DiCaprio 2015. Exostosis caused by mutation in EXT1, EXT2, and EXT3 genes, a tumor suppressor gene. This leads to decreased production of heparin sulfate by chondrocytes found at the physis. Individuals with the EXT1 mutation have a more severe presentation compared to patients with the EXT2 mutation, including higher rate of chondrosarcoma, more exostosis, more limb malalignment with less forearm and knee range of motion, more pelvic and flat bone involvement, around 5 to 10% malignant transformation to chondrosarcoma in patients with MHE, whereby the proximal lesion more likely to undergo malignant transformation than distal lesions. Formation of exostosis. In the growth plate, proliferation zone of chondrocytes is responsible for bone elongation. During this process, cells from the upper layers proliferate, while the cells from lower layers undergo apoptosis then calcify. As a result of mutations in the EXT1 and EXT2 genes, chondrocytes with shortened heparan sulfate HS chains appear in this area. If the cell is located in the middle column, it can rescued by the neighboring cells with normal length HSA chains. Therefore, exostosis is not formed. If the cell is present in the outer columns, it escapes from a normal differentiation process. The cell loses its polarity but still keeps its proliferation potential. Then the cells start to translocate to lower layers of chondrocytes and grab some non-mutated cells with it too. In the last stage, the cells form exostosis. Please note, not all cells with shortened HS chains give rise to bone tumors. This is by Jones, 2011. Pathological bone formation are usually found in long bones, but rarely also in flat ones. By Alvarez et al. 2006. This figure shows the formation of exostosis in the area of growth plate. We can see the epiphysis, then the growth plate, the zone of the growth plate, the resource zone, proliferating zone, hypertrophic zone, the calcified zone. So there is a mutation of EXT1 and EXT2 genes affecting the proliferating zone, especially the chondrocyte. So there will be a mutation, especially in the cells in the outer column. So these cells will become elongated and there will be a formation of exostosis. There are two types of exostosis. Number 1, solitary exostosis. Number 2, hereditary multiple exostosis, HMEs. Multiple hereditary exostosis, usually a male predominance, autosomal dominant, inheritance. There are variability in size and number of exostosis or osteochondromas. Any portion of the skeleton in the cartilage may be involved, usually evident during childhood. MHE may be bilaterally symmetric. One side may predominate. For the formation of malignant transformation, multiple cartilage cap exostosis in the course of MHEs develop in childhood and ossify when skeletal growth is complete. The bony outgrowths are benign tumors, although they can transform into malignant chondrosarcoma in around 3.9% of patients, by Jones et al. 2014. Chondrosarcoma transformation usually occur before the age of 40 years old and in 87% of cases involve the appendicular skeleton, with the most frequent localization involving the pelvis, followed by scapula, proximal femur, or spine and the rib. Chondrosarcoma is usually low grade, but the main limitation for surgical excision is due to close location of the tumor to the principal neurovascular bundle. Clinical manifestation. HMEs are rarely detected at birth. Usually, they gradually develop during childhood and adolescence and cease to grow once the epiphyseal plates become mature. By Pedrini et al. 2011. The average number of exostosis per patient is 15 to 18. However, it varies considerably among the affected individuals and range from 2 to 172 osteochondromas. By Clement and Porter, 2014. HMEs may develop in bones formed in the process of endochondral ossification, most frequently long bones. One of the most commonly involved bony regions is the knee area, with exostosis occurring predominantly in the distal femur around 70%, proximal tibia 71%, and proximal fibula 27%. Although HMEs predominantly locate in the skeleton of the lower extremities, extremities. Other frequently affected bones include humerus 50%, ulna and radius 30%. Less common locations involve the hands, the ribs, the scapula, vertebrae, and pelvis. The clinical severity of the disease depends on the total number of exostoses as well as their size and shape. Osteochondromas typically projects away from the epiphysis and may be pedunculated and sessile or sessile. The osseous tuber is called pedunculated when it is slender and has a narrow stalk. This form tends to irritate the surrounding tissues, leading to local trauma. The sessile tuber has semicircular or mound shape and attached to the bone with a broader base. Some authors suggested that pedunculated morphology and the massive exostosis with greater cortical involvement associated with notable shortening of an involved bone. Stieber and Dormans 2005. This X-ray shows the pedunculated type of osteochondroma, projects away from epiphysis, and there is a narrow stalk. The common disease complaint is pain. Pain is due to irritation of structure adjacent to bone tubers, but also from the joint malalignment or bursitis. Exostoses are located in the proximity of the joint, limiting their range of movement, restricting their flexion or rotation. Due to an overgrowth of the epiphyseal plate, osteochondroma may interfere with skeletal development and give rise to limb deformities. Disproportionate bone shortening can result in joint malalignment, bowing, subluxation or dislocation of adjacent bone. These deformities include Madelung-type deformities of the wrist, hand involvement including brachydactyly, pseudomallate fingers, angular deformity, coxa valga, acetabular dysplasia, journal valgum and valgus angulation of the ankle joint. Limb length discrepancy is frequent. Apart from the local effect of osteochondromas, they can present as scoliosis or short stature. A rare and atypical complication of MHEs include thoracic exostosis that give rise to pneumothorax, diaphragmatic rupture, hemothorax, coronary artery compression, and severe chest pain. Cervical osteochondromas can cause neurogenic and vascular thoracic outlet syndrome as well as dysphagia. Malignant transformation around 4% in regions such as pelvis, scapula, and proximal part of femur. Tumor arising from endochondral elements of the cranium and defects of the cranial base, especially cleavers, are also common but easily missed. Yay, we have reached to the end of this video. See you in the part 2 video. Take care and bye.